right, welcome back, everybody. We are here with Dr. David Kulber, and our name of our new podcast for medical stuff is Endotopic, and we are at the cutting edge of surgical discussions and conversation, which is great. So, Dr. Kulber, you're from Cedars-Sinai. That's where you're working, right? And you're a hand surgeon there, plastics and ortho. Am I correct in that?
That is correct.
And a bit of hand surgery there, too?
A little hand.
Yeah, a little hand surgery.
Yeah.
And we were in our last one, we were talking about carpal tunnel and doing all that nice, fun stuff. But you have come up with something that's, I think, ingenious and brilliant and simplistic, and it takes away nothing from the body. So what I mean by that is most surgeries, when you're dealing with, especially with hand surgery, you're implanting something, you're removing something. And with this, what you're doing is you're just taking the meniscus, shaving it, reshaping it, and putting it into the joint space after you decorticate and creating a new articular surface.
Yeah,
Am I correct in that?
You're improving something. It's actually improving
Yes.
it. Yes, you're using the body to heal the body. And it's biologic reconstruction of joints. That's the idea behind it.
I like it.
I realize that people are getting older, they're living longer, and if you live long enough, you're going to have arthritis in your hands because hyaline cartilage, which is the cartilage that lines our joints, is really not that durable. It's not meant for people to be around at 80 or 90 years old. Even 60 or 70, you begin to feel it.
Yeah.
Our life expectancy has really increased a lot with all these other medications and the different things we've been able to help the human experience improve upon. The one thing that we haven't done a great job on is the biologic of our joints now that we're living longer, and very little research has been done as far as the biology of joints. So like now what we do for joint reconstruction is that we put like metal things in us, like implants, like for knees and hips. And it always reminds me of the Star Trek show when Bones goes back to like the 1940s. It's an episode with Joan Collins. Like
it's my favorite episode.
And he goes, the barbarianism of it all, the blood, the knives. What are these people doing?
He's like, what is this, the Dark Ages, Jim?
Yeah. And when I see like a metal, like doing a hip and knee replacement or putting metal into people, I'm like, God, that's like so barbaric.
Totally.
Now, we're going to look back at this and like, what were we thinking? Because now we've had we were able to regenerate livers and pancreas and do all this other cool stuff for our vital organs. But for the exoskeleton, we're like just doing like crazy, like just putting in like metal that, breaks down over time, loosens, gets infected, instead of thinking biologic solutions. So the meniscus it's cartilage, it's fibrocartilage. And the way I came up with it is that one day many years ago, I had an artist who was this big Swedish guy who had a third metacarpal osteoarthritis. And he loved to sail, and he was a sculptor, and he just couldn't use his third finger anymore. He couldn't bend it. It was so painful. And so typically the treatment for that would be either putting a silastic implant in, which would break in like a matter of months because he's such a big guy, or you fuse the joint. And he's like, you're not fusing my joint, doc. You figure out another way to do it, and I'll do it. And so I'm part of the Musculoskeletal Transplant Foundation, MTF, and I go there a couple times a year, and I look at what they're developing. And so one day I'm in lab, and I'm looking at this meniscus, and I'm thinking, well, fibrocartilage, and it was like in a 70-year-old person who passed away, but their meniscus was there, and it looked like brand new. I'm like, well, meniscus is like really sturdy. It doesn't require a lot of blood supply. It's very strong. It doesn't break down. Look in the 70-year-old
When you say
guy.
supply, you mean blood supply?
Yeah, doesn't need a lot of blood. It doesn't need a lot of nutrients. You could just put it on the table and it might live. Sprinkle some water on it. I don't know, but it
starts crawling away.
Yeah, just so
Naked Gun style.
Yeah, right. Yeah, leave me alone. Okay. Yeah, bye. Okay, so the and if it's a meniscus, it might run.
Yeah, nice.
Fast, yeah.
But it is really strong. You're right. It's fibrocartilage, so it's extremely strong.
So it's much better than hyaline cartilage. So I think like if you were to design a new joint, you'd want fibrocartilage because that stuff doesn't fracture or break. It's lined and it's hard for it to break down, as opposed to hyaline cartilage, which is very fragile.
Yes.
And those cells, once they're damaged, even with trauma, when you break your wrist or your finger, you get arthritis because those chondrocytes just die.
Yes.
But fibrocartilage is a whole different deal. They don't have chondrocytes in it, so it's very sturdy and strong. So I'm thinking to myself, well, what if I put that into a joint? It's a smooth surface, and if you cut it in half, the undersurface is very fibrous, so you can get like stem cells from the bone if you decorticate it to grow in. And frankly, you're not doing any damage because if it doesn't work, you didn't do anything, and the joint's already arthritic. So
and you haven't removed anything.
Yeah, you haven't damaged anything. It's just, we'll try something else. So it seemed to me like it was the complication was very low if it didn't work because you just have to fuse it or do something, or you could still put an implant in. You're not actually, burning any bridges.
Right.
So we did it, and to my surprise, it completely worked. It was about 10, 12 years ago. The guy's totally fine still. He's got full range of motion, sales, does everything he wants, and it survived for that long. And so, and I realized that it turns out you only need one smooth surface. Initially when I did it, I thought if you had two arthritics, you'd have to do two, but you just need one smooth surface, and it works. So, because you just need one smooth surface for the joint to articulate with.
Yes. And now we call the product now Avivo, and we should go back to talking about like you were on the back table at one point, like cutting this thing, right? And then we now have a process that MTF does that makes this fibrous on one side and then smooth on the other. And I think what it does interoperatively for the new surgeons that I've trained is that it makes it easier for them, because once you slide it in, if it was smooth on both sides, it would be all over the place, right? The fibers actually hold on to the decorticated surface as you're suturing it in.
Yeah, I mean, it turns out, there's a little bit of a learning curve, but what I learned, I used to put in a ton of sutures, and now if you just decorticate the bone and you put it in correctly, it's like maybe 2 or 3 sutures and that's it. And
top.
Yeah, like on either side or on top, and that's really all you need. You don't need a lot of fixation because it just sticks there, and then you close the joint, and then where's it going to go? It has nowhere. Right. It has no place to go. It's not going to it can't escape through a hole or anything.
Yeah, it's not like you're running on your hands.
Yeah. Right. So it's stuck there,
yeah.
And so you just let it sit there for a little while, and then you get this. And it turns out in some of the pig studies we did with this, that within 3 to 4 days, it's already adherent to the bone. Like it's stuck to it, and within a week, you can't even separate it from the bone.
You can feel it when you put it on.
Yeah.
It sticks to the bone immediately.
Yeah.
And it's actually like grippy. And
it's like a glue. Yeah.
Yes.
Yeah.
Yes,
like glues
amazing.
right in. Yeah.
Yeah.
So very cool. And
so these are the processes you went through, right? Like you were putting it on either side of the joint, and then you're like, okay, I only need one piece, and then you were like, okay, it needs to be thinner. Right, so that's when you started shaving it?
Yeah, so some of the stuff that we did, we looked at like it's like first I did it in some people. We did this kind of backwards. Before I realized how it worked or what you do with it, I just put it in somebody.
Yeah.
And then I realized, it works. Well, how does that work? And what's the science behind it? And what's the optimal way of doing it? And it turns out that you really don't need a thick piece. Initially, you're thinking like maybe it's a cushion that you're putting in. But in fact, that's not what you're doing. You're just giving a matrix for the stem cells from the bone to grow into it and then revascularize it. So if you make it too thick, then it takes much longer for it to grow in. If you make it really thick, I don't know if it would grow in, but there's like a sweet spot for the thickness where you get pretty quick vascular ingrowth within a couple weeks. That then you could start moving the joint within 3 weeks, which is what you want. You don't want the joint to get stiff. Yeah.
What do you put them in like if you're doing a CMC, do you put them in a splint or a thumb spike or something like that?
Put them in a thumb spike, a splint. Yeah. And really it's not, my concern most of the time isn't really the meniscus taking or revascularizing. It's really more the ligaments around the joint healing to hold everything together. But it's usually the rate limiting factor about motion and failure isn't the meniscus itself. it's the collateral ligaments and the dorsal capsule and everything around it that needs to heal after you do this.
Yeah, I always like try and tell them like do a really nice dorsal capsule closure, do tight. And you use do you use like the internal bracing too?
The failures that I did have were like patients who had previous cortisone injections because they've had like 4 or 5 cortisone injections before. This is for the thumb joint particularly. So the tissue, even though it might look normal, it's not normal. It doesn't heal well. And over time, what happens is even if you close the joints really tight and it looks great and it feels good, over time that tissue loosens because it's not healthy tissue. It's been injected with cortisone multiple times. So you get like a little laxity in the joint, and then you can get a little laxity in subluxation that can be a little painful. So now I pretty much do an internal brace on people if they've had cortisone injections, just to obviate the even worry about that. And since I've done that, there have been no issues at all. That's really, I think, the biggest thing to worry about is just the dorsal capsular closure. But once you use an internal brace, that obviates it. And you don't have to use it on everyone. If you're doing a young person who's never had a cortisone injection, you don't need it. It's really the people who've had previous injections. And then oftentimes you don't know like what they were injected with. Do they use Kenalog 10? Do they use Kenalog 40? It's very deceiving because the tissue can look normal. Sometimes it's pretty obvious. You see cortisone precipitated in the joint. You know, they've been cortisoned out.
It's like you could see it.
Yeah, you can see like this white stuff in the joint.
It looks like putty.
Yeah, and you're like, oh, that's too bad. Yeah. But I think you just have to...
now, would you remove that when you were putting the meniscus in?
The cortisone... Yeah, I mean, you do... Like, one of the things you do when you're doing with all joint surgeries, most of the pain that you get is from the synovitis, the inflammation. Yes. So you want to take out all the... synovitis, use a Ron Jerry, just pull all that stuff out, and then you go ahead and put the meniscus in after you decorticate. But then the key is the capsular closure. I think that's, the meniscus is actually very easy to put in. You just have to, and sometimes what you could use is you could use the thumb, like abductor and EPB to kind of reef it over the dorsal capsule to reinforce it. And you don't always need the internal brace if you have good, healthy tissue.
All right. Those are like amazing
Those
pearls.
are little pearls. Those are after doing 8 bazillion of these and seeing where the complications
you need to get that on a card
are.
For everyone.
Yeah.
Those are really good pearls.
Yeah.
I mean, those are all questions I get different people, and they'll ask certain things like that. So that's really good information.
Well, it's like any new operation and new technology. You continue to refine it and figure out, where the pitfalls are. I mean, where the complications occur. And even if it's one complication, you learn from it and, make it just better and more reproducible. So I think we're at a point now where I could tell you that like 98 to 99% of the time, I've got the tools to make it work regardless. And I'm very aware of all the pitfalls of this operation, something that I couldn't have said a couple of years ago.
Now, how long have you been doing the operation?
For at least about 10 years.
That's
and I just slowly built up. I mean, the basilar joint, the thumb joint, was the last joint I addressed. Because
what was the first?
The first was the metacarpophalangeal joint of the, in patients who have terrible arthritis, they don't have a good solution.
Yeah,
so
MCP.
there's no great solution for that. So I'm a winner there because I can't, whatever I do is going to be better than what they have, right? So that's what you want to do. And the same thing with PIP joints, which was the next thing I addressed, because PIP implants fail, they break, they loosen, and then when those fail, you get a fusion and it's terrible. So you can't bend your fingers. So it works very well for PIP joints. The biggest thing with PIP joints, again, is the collateral ligaments, because most people with arthritis in their PIP joints do have laxity.
Yes.
So you have to how
do you address that?
You have to repair it either using directly or like suture anchors. I think what we now have that we invented or designed and patented is cadaver collateral ligaments from the knee. So that's kind of cool. That's coming down the pike. So we're doing a study on that. And we did a biomechanical study, and that works very well. And it's stronger than palmaris longus or other types of ligaments. So it's as good as the native ligament. So I think that's the next step to figure out how to do that to strengthen collateral ligaments.
Love it.
Because you can't really use the internal brace on fingers. It's a little too
small of an area.
Yeah, too small.
Yeah, especially on PIP.
Too small. But I think that's a really important point. And
DIP.
then we went into the wrist, and that was the other one. Where patients are getting radiocarpal arthritis. We have a big series on proximal carpectomies where you still have arthritis either in the lunate fossa or the head of the capitate, where you would try to do a flap or interposition flap, but oftentimes you don't have enough tissue for that. Just put a piece of meniscus on it and you're done. And it's very simple to do and very easy. So now like wrist fusions, I haven't done a wrist fusion in years. In fact, that's the one issue we have with our fellowship is that our fellows don't have enough wrist fusion surgeries because we don't do them anymore. It's like, and there's like a requirement for wrist surgery to graduate, but we're like, oh my God, we're gonna have to send you to another country that doesn't have this technology to
learn it.
Yeah, because I will never do another wrist. I will never say never, but I've not done a wrist fusion.
I never understood it.
Yeah.
I never understood why they did it.
Yeah.
Like it made no sense.
Well,
to
there's
me.
no, wrist implants don't work well. They loosen they're problematic.
They were popular for a while.
They were, and then until they had a lot of failures. And once you take the bone out, then you've really burned your bridges. So this doesn't burn any bridges. We're just relining the joint of the wrist. And we've had such great results with it. It really is a game changer in my mind.
I agree. And you also said that you were doing it for DRUJ.
Yeah. So that's kind of, you do everything. You kind of have to build up and do it using this technology. You just don't want to, you want to make sure that it works. You want to do one joint at a time. And that was my goal, just to start out doing one thing at a time, make sure it works, understand the pitfalls of that joint, then move on to another joint, and then another joint. I just didn't jump in and just throw meniscus in everybody. Oh, everyone gets a meniscus.
Everybody gets one.
Yeah. You get one, you get one,
it's a prize.
You get one. Everyone gets a meniscus.
Everybody gets a meniscus.
Yeah.
It's your birthday.
Yeah, it's an Oprah show of meniscus. You get one.
Look under your seat.
Yeah.
It's a meniscus.
There's a meniscus.
It's a meniscus under my seat.
Yeah. You've got arthritis. You get a meniscus. Okay.
Yeah, totally.
So, you just went one joint at a time, and then finally, went to the DRUJ is a big problem for, and the DRUJ is a joint, the sigmoid notch, there's cartilage there, and when that cartilage wears down, so it turns out that you just need to reline the sigmoid notch, and then the big thing is just making sure that the distal radial ulnar joint itself is stable, and it articulates well, but in the right patients, people who just have distal radial ulnar joint arthritis, it's a great solution instead of doing like a Dara resection, cutting off the distal radius, or a Suavi-Kapunji, where you fuse it. Yeah. Because that part of the distal ulna that's unstable, it can create havoc. Yes. And there is no great solution for that. It's torture. It's an operation that you really don't ever want to have to do, because that distal ulna can be very problematic no matter how you try to hold it down. Once you let it go free, it's very problematic. So like in older people, you might be able to get away with it.
Impaction syndrome too.
Yeah. So you got to be very careful with that. Those resection of the distal ulna. So this obviates that, but it's really only for patients. You have to select the right patient for it, but it's a game changer for that.
What's the right patient? Stable?
A patient who maybe has distal radial ulnar joint.
Yeah.
Mentally stable.
Stable. Yeah, there you go.
Someone who will actually listen to their doctor and not take off their cast in 5 minutes and leave and go, oh, I'm okay.
Do handsprings.
Right.
Yeah.
The right patient, someone who's got good stable ligaments and isn't like subluxing their distal radial ulnar joint themselves, but just has arthritis in the distal radial. That's the ideal one to do it on.
Right.
But then, but if they do have some dorsal translation, you could stabilize that at the same time.
Yeah. Okay. And you said you did the capitate, but is there anywhere else that you think in the body that this meniscus could be used for? Oh
yeah, so I've used it in every part of the hand. It works great for like fifth CMC joint arthritis. Nice. We're writing a paper on that. People who have it's called a baby Bennett's fracture, an interarticular fracture of your fifth metacarpal base. and it gets distracted a little bit, but sometimes you don't notice it, or it doesn't look bad enough to treat it, but then you get arthritis because those chondrocytes are very fragile. And so then you have pain in that joint, and there's no great treatment except fusing that joint. And even fusing, it's very difficult to fuse CMC joints in the fingers at the base of the fifth metacarpal. So we put meniscus in, and it totally works great. Elbow defects, chondral defects in the elbow works very well. And so that's kind of where we are with this right now. We looked at like using it for knees, and we're like kind of like playing with that. That's a whole different deal because it's weight bearing. It has to get revascularized. You really can't immobilize the knee, and it's bigger. So I think the future of surgery and tissue design is going to be actually designing tissue like matrix is, and then using like a matrix very similar to fiber cartilage, and actually creating it, growing it in the lab.
And then, a substrate?
Yeah. And then,
interesting.
I mean, that's really where the future of medicine is going to be, is like growing this type of substrates and then using stem cells and putting in like adipose-derived stem cells, using the decorticated bone, because bone has stem cells when it grows into it, and let that differentiate into the matrix that you make for it to grow into.
Right, exactly. And then you could make it any size.
Correct.
Yeah, which would be amazing.
Yeah. Wow. So I think that's like where tissue design is going. It's very exciting. Probably like a good decade away from that becoming a reality.
Okay.
But design, just using something like fiber cartilage, but actually making it instead of like taking it from
donors.
From donors, yeah.
Yeah. That's interesting.
But it's very effective to take it from donors just because it's there. And it's been donated. It's human tissue. It's been donated. People always wonder, like, is it going to get rejected? No, it doesn't, because what the techniques are, which are very scientific and very smart, is that it basically gets rid of all the DNA. So all the proteins is denatured, and so there's no DNA in the tissue. It's just the structure itself.
Interesting.
So there's zero incidence of rejection because it's just a structure with growth factors in it and different factors. We tested for like endotoxin, not endotopic, but endotoxin. So there's no like toxins in it, and it's very inert. So it's just going to be there, and things need to grow into it.
Do you think that's why it gets a bit revascularized?
Oh yeah, because it's just a structure.
Because it's not regular meniscus then.
Well, it's not regular meniscus in that there's no living cells in it, but it does have growth factors in it and all these other factors that attract cells.
Sure.
So it actually sells.
They're like, come in
let's
here.
come in here. This is a safe spot.
You guys are gonna like this place.
Yeah. This is a safe location for you to hang out. Yeah.
It's a good spot for you to grow.
Yeah.
That's great.
Come on over for some coffee and
a little tea, cigarette, whatever.
Yeah.
It's funny. MTF does all this work. Like I just distribute it, but MTF does all the work. So they create this the meniscus. They get rid of all of that DNA, like you were talking about, and they shave it and package it.
Yeah, MTF is an amazing organization. It's Musculoskeletal Transplant Foundation. I became aware of it because I used a lot of it for like different breast reconstructions and things like that, using acellular dermal matrix. But MTF was started by orthopedic surgeons in New York, and it's a nonprofit. It's the largest tissue bank in the world, and it gives back all of the money it makes into redevelopment and grants to increase their scientific mission of using tissues to heal the body, your own tissues. So it gives back, which is really, really nice. People don't really realize that, but it takes all the money that it makes and puts it right back into the science. It has about 84 patents right now. I have a couple of patents with them. And it really it's really made for improving the science and the quality of people's lives. And so it's a great organization, and it has a great mission statement.
Wow, that's fantastic. I mean, it's just, and I met the CEO today too, and he's just a great guy, and he'd been working at that company for 20 years.
Yeah, I mean, it has a special culture to it.
Yeah.
So because it appreciates tissue donor, it holds that tissue as very special, like a holy grail, and it treats it such. You know,
Right.
they take all the tissue donation and all the products that they make. They really respect that because, you know, people have donated their lives for this, and families have. And so they take it very seriously, and they're very appreciative of it. We always have, like, before we have a board meeting, a connect to purpose, and we do a story of, like, one of the donors and how it changed someone else's life. And it's always very moving. And I think that's the great part of, like, humanity, like people helping people.
Yeah.
You know, the Barbara Streisand song, people helping people.
Yeah.
So,
I mean, isn't that why we created society?
Yeah. I
right?
mean,
And why we're all here doing this?
If we could all be like that, it would be a
great.
much better place. And so the people that are involved in MTF have that. It's more than just a company. It's really a very important culture.
Yeah.
And luckily, Joe Yacarino, who's the CEO, when we were, I think I was telling you this earlier today, when we were looking for a new CEO because Bruce Martyr retired, we took some people from the outside, and Joe was the inside candidate. And it was just clear Joe really understood it, and we're not there just to make money. We're there to help lives and advance the science and really appreciate the donation and understand that and keep respect it and keep that within the culture of the company. And he's done a great job. Very
I like him a lot. I think he's a good guy, and you know, he really appreciates the company and what you guys are doing. He has a lot of respect for the industry and for you, and it was a good culture. I'm going to go down and visit him.
Yeah, and he's a great musician too. He's got a group called the Bones,
of course,
the Bone Tunes, I think, and he's great. He'll play some music for you.
Oh, it's fantastic. All right, well, we're going to wrap this up, JP. The Avivo is a product that you can get through Abe Surgical. It is the meniscus, and it's produced by MTF. And if you've got arthritis and you know you've got some hand issues.
You want to start a revolution and fix people with arthritis?
Yeah.
Avivo, man. Yeah. It's really going to change the way you think about it. Not, you know, instead of taking out bones or fusing bones and, you know, being like Bones in Star Trek, it was barbaric.
Oh, right back to Bones.
Right back to Bones. Yeah.
I'm a doctor, Jim, not an escalator.
Well done.
Yeah. All right. On that note, we're going to end it off. Dr. Kulber, thank you so much for being with us.
Thanks for having me. Okay.
Real
Very
pleasure.
Good. Yeah.
Real pleasure.
Awesome.
Awesome. All right. We're signing off. Take care.